Hi, I'm Dr. Bill McIvor. I'm a professor of anesthesiology at the University of Pittsburgh School of Medicine and a staff anesthesiologist at the University of Pittsburgh Medical Center. This video series was created to introduce you to concepts underlying comprehensive hemodynamic monitoring. Hemodynamic monitoring involves evaluating the components of blood flow. As clinicians, we're trying to determine if low flow or pressure is limiting oxygen delivery to vital organs. Traditionally, hemodynamic monitoring was accomplished by simply measuring heart rate and blood pressure. Engineers know that it's hard to measure the flow of fluid through a pipe, but it's easy to measure the pressure generated by the flow. In something like a non-distensible pipe, pressure is directly proportional to flow. More pressure. Less flow, less pressure. The challenge for healthcare providers is that the resistance of the pipes that we measure pressure in is not static. The vascular resistance changes continuously, meaning that pressure and flow are not directly proportional. In other words, blood pressure doesn't always equal flow. You've probably learned this important relationship. Blood pressure equals cardiac output times systemic vascular resistance. Because cardiac output and SVR are dynamic parameters, not all blood pressures are created equal. Let's look at two examples. In low flow states, physiologic compensations raise the SVR. The patient may have a normal or even high blood pressure that is the result of supraphysiologic systemic vascular resistance. In this condition, the normal blood pressure that is the result of low flow and high resistance could result in poor oxygen delivery. Conversely, in high flow states, such as gram-negative sepsis, hyperdynamic patients could have a normal pressure that is the result of supraphysiologically high cardiac output that is in response to very low SVR. As you can see, despite having the same blood pressure, the flow may vary quite a bit. That's a great example of how abnormal hemodynamic conditions could be missed if only blood pressure is measured. How is blood pressure measured? Most commonly, it's done with oscillometric blood pressure cuffs. These cuffs measure the oscillation of an artery as a function of pressure. They inflate to a pressure high enough to arrest blood flow through the artery, stopping it from oscillating. They then deflate and detect the oscillations, the vibrations. The point of maximal oscillation corresponds closely to the map. The systolic pressure and diastolic pressures are estimated based on algorithms. The advantages of oscillometric blood pressure measurements are they do not cause harm to the patient, and the cuff can be set to automatically and repeatedly cycle. The limitations of measuring blood pressure this way are the cuff only measures the mean arterial pressure. The systolic and diastolic pressures are estimated. The cuff needs to be properly fitted, or the measured value may be falsely high or low. At both very low and very high blood pressures, the readings from an oscillometric blood pressure cuff are less accurate. When the blood pressure is very low, the oscillometric cuff is likely to incorrectly overestimate the blood pressure, and at higher values, the cuff may inaccurately underestimate the pressure. Though they can cycle intermittently, blood pressure cuffs cannot practically measure pressures any more frequently than about every 2 minutes to avoid injuring the limb being measured. Let's think more deeply about the limitations of intermittent blood pressure monitoring. If you're caring for a patient with a blood pressure cuff over a 3-hour period and you set it to cycle every 3 minutes, you'll only make 20 measurements an hour, or 60 total measurements. That means you will only have insight in the patient's blood pressure for about a third of the time you're taking care of them. What's happening the other 66% of the time? Blood pressure isn't static. It changes continuously, so intermittent pressures could miss significant and repeated hypotension. In fact, one study by Chen and colleagues demonstrated that an average of 7 minutes per hour of hypotension could have been identified with continuous monitoring. Other studies have demonstrated that continuous blood pressure monitoring detects a significantly higher amount of hypotension compared to intermittent oscillometric monitoring. This is very important, as we know that intraoperative hypotension has been associated with complications, including myocardial injury after non-cardiac surgery and acute kidney injury. Early detection of hypotension with continuous hemodynamic monitoring allows for timely interventions that could reduce the incidence of intraoperative hypotension. Cleveland Clinic researchers have even demonstrated that continuous non-invasive blood pressure monitoring reduced the amount of intraoperative hypotension by nearly a half when compared with intermittent monitoring. If you're with me so far, you recognize that blood pressure measurement is logical to perform and important to do, but that not all blood pressure measurements indicate normal flow states, normal hemodynamics. Logically, blood pressure, cardiac output, and the determinants of cardiac output, including SVR, should be measured continuously to avoid hypotensive episodes and provide a more comprehensive understanding of flow to vital organs. Doing so through either arterial-based or non-invasive monitoring will help us make the best decisions to care for our patients' hemodynamics. You can learn about a few of these monitoring options by visiting the Edwards Clinical Education website. Tune into the next Critical Insights video, where I'll be examining the determinants of cardiac output. Like this video and subscribe to stay up to date on these clinical educational videos, symposium recordings, and more. You can also visit edwards.com/clinical education to find in-depth resources and tools to help you solve the clinical challenges facing you today and in the future.